Okay, so what is the best time of day to have an argument with a lady in menopause? So the time of day doesn't matter as long as you do it in 5 years from now. Okay, tough crowd. Okay, where does a menopausal woman find fashionable glasses? On her forehead. All right, so menopausal jokes, you guys are not quite with me there. So let's try a doctor joke. So a lady goes to see her doctor, and she's having just massive headaches, and so they go through all the diagnosis stuff, and he comes back and tells her, he says, "Ma'am, I have bad news for you. You have a brain tumor." And she says, "Well, I'm 15. I don't want to die. What can I do?" And he said, "Well, it's modern medicine. There are a lot of different treatment options that we have and a lot of things that we can do, but unfortunately they're very expensive and insurance won't cover them." And she said, "Oh, well, money's no object. Like I said, I'm young and I don't want to die." And she said, "Okay, well, what we can do is we can do a brain transplant. You can either get a male brain, it's $1 million, or you can get a female brain, it's $25,000. And she said, "Well, again, I told you that money's no object, but why is a male brain so much more expensive?" And he says, "Well, because a female brain is used." Okay. I had one more, but I'm just going to move on. I won't tell you any more jokes. Okay, so menopause. Let's just kind of go through, again, some of the basics. This is my goal for today. We will define menopause and just describe it. Again, many of you are going to know a little bit about that. We're going to talk specifically about treatment options. We're going to spend a good bit of time on hormone replacement therapy because that's probably where most of the interest is. We'll talk about some non-hormonal treatments as well, and then we'll spend some time asking questions. So what is the definition of menopause? So menopause is defined as the time in a woman's life when the ovaries stop producing eggs, she stops making hormones, and she stops having periods. So that's basically what menopause is. If you needed a one-word or a two-word definition, it's ovarian failure. So basically the ovaries have done their job, they've done what they were called to do, and then it's time for them to kind of ride off into the sunset. It's important to understand that it's a normal physiologic process. So going through menopause is not abnormal. There's nothing wrong with it. And it doesn't necessarily require any treatment. A couple of just terminology things. Menopause is a transition that begins from the time that your periods change, and then it's considered to be over when you have not had a menstrual period for more than 12 months. Okay, so menopause is when your period has not been there for more than a year. The transition from the beginning when all this happens to the end is called perimenopause, and then postmenopause are all the things that happen after menopause is over and done with. So a little bit of background things. The mean age of menopause in the United States is 51. 95% of women will go through menopause from the age of 45 to 55. And I always tell people some women are, they're 52, 53, and they're wanting to know when is my menopause coming? I'm ready to be done with all this. And I tell them that, just when you look at statistics, for everybody that's 45 and goes through menopause, somebody has to be 55 and go through menopause, just to basically make the numbers add up. So some women are sooner, some women are later. One thing, this is not an endorsement of smoking, but smoking makes menopause come usually on average about 2 years sooner, so 49. So if you're a smoker, that's one of the few benefits. Menopausal symptoms are very common. I mean, there's very few women that do not have some symptom. I mean, they vary in severity. Some people describe debilitating symptoms. Some women will just notice that they have a hot flash or night sweats from time to time. And then we talked a little about perimenopause and postmenopause. So what is happening? And I won't bore you with a long physiological explanation about what's going on, but your ovaries are not functioning the same way that they used to anymore. So they're not producing eggs to the same degree that they did. They're not making hormones the same way that they used to. Estrogen, progesterone, and a little bit of testosterone. And we'll talk just briefly about testosterone. And then you have, in the hypothalamus in the brain, you have some thermoregulatory changes, and that's why women have hot flashes. Truthfully, it's not very well understood what happens and why it happens, but we do know that you have this set point of your temperature regulation in the hypothalamus, and then as you have a hot flash, there's a drop in the set point, and it causes that characteristic hot flash that people will describe to you. So again, just what is actually happening, you have the uterus here, and then the ovaries and fallopian tubes on either side. So one uterus, 2 ovaries, and 2 fallopian tubes. This is what is happening in the menstrual cycle every month. You develop and you build up a menstrual lining every month, getting ready for that egg that comes out of the ovaries to implant in the uterus. You get pregnant, you make a baby, and that's kind of what the whole cycle is. Well, when you go through menopause, that's over and done with, and so you no longer build up that endometrial lining, so you don't have to have a period anymore. This is estrogen right here. And then you have progesterone, which you can't really see, but it's kind of coming up right here. And both of these hormones will withdraw at the same time, and that's what causes the menstrual cycle. So again, all this being the normal physiological process that happens, this basically all comes to a conclusion, and you don't have periods anymore, and that's basically menopause. So a little bit of background. The mean age, or we talked about some of that stuff, about when, why, all that sort of thing. And these are just some of the risk factors. Some of these things will cause menopause to be worse. Some will cause these things to be early, and we won't go through every one of those things. But a few things about it. Obesity is associated with worsening hot flash symptoms. Race is not very well understood. We do know that Asian patients or Asian women have fewer menopausal symptoms than Caucasian, Hispanic, and African American patients. Smoking, again, makes menopause come a little bit sooner. Sedentary lifestyle tends to exacerbate or make menopausal symptoms worse. Socioeconomic status tends to play a role in that. There's something about education levels that for whatever reason, higher educated patients have less menopausal symptoms. Again, all these things are not well understood, and there's really no rhyme or reason to that. But I mean, there is some information out there on these things. Okay, so what are menopausal symptoms? And I tell people there are 5 things: hot flashes, night sweats, vaginal dryness, mood changes, and sleep pattern changes. And those are kind of the big 5. Okay, that's really 4 because hot flashes and night sweats are basically the same time. The night sweats just come at a different time of the day. So a night sweat is basically a hot flash that occurs at night. Vaginal dryness is a result of decreased amounts of estrogen in the vaginal tissues, and so you have more brittle, the term is atrophic tissue in the vagina, which tends to cause maybe a little bit of bleeding. It can cause pain with intercourse, and so that's one of the more characteristic things that people will complain about related to vaginal dryness. Urinary symptoms are associated with this as well, and we'll talk specifically about the impact that menopause has on urinary symptoms in particular. Emotional instability. And there are a lot of different things. Depression is one of the factors that people will talk about, but it's usually irritability and anger and shorter fuses. Those are the things that people will complain about as they get into their perimenopausal years. And then sleep pattern disturbances as well. And again, that is not the primary reason that women have some sleep pattern changes is because they're getting up in the middle of the night because they've had hot flashes, they change their sheets or change their pajamas. That's one thing. But it also does change your circadian rhythm and your REM sleep cycles and those kind of things. So even if you don't feel like you're having hot flashes, you can still have some sleep pattern changes as well. One of the things that we do know about night sweats is that night sweats tend to usually come in the first 4 hours of sleep. So if you can kind of get through those first 4 hours, then people tend to do a little bit better. And so we all know people, not that it's any one of us, but we all know people who will go through these types of things. This is psychotic at the bottom. She's my favorite. Okay, so diagnosis, you really don't need, there's not a biopsy that you need to do. There's not a specific blood test that you need to do. You basically describe your symptoms and we all kind of know what you're talking about. So that's how menopause is really diagnosed. If you did do a laboratory test, there's something called a FSH, a follicle stimulating hormone. That's typically elevated, and that is indicative of postmenopause or menopause. And basically what happens there is your hypothalamus makes a hormone. It goes down to your anterior pituitary that makes a hormone. That's where the FSH hormone level is made. It is circulated in your bloodstream and is designed to go down to tell your ovaries to make hormones. And so when your ovaries do not respond the way that they're supposed to, your body is going to do what we all do with our kids, or at least what I do. You either yell louder, make more hormone, and so you make more of that hormone to try and work harder to get the ovary to make the stuff that it's supposed to be making. And so that's why you have an increase or an elevation in the FSH level. But this is not a requirement. You don't really need to have an FSH level to know if you're menopausal or not. Oh, vasomotor. Okay, thanks. Thank you for doing that. So menstrual changes, let me just go through these. Menstrual changes can mean a lot of different things. Your periods get heavier, your periods get lighter, your periods get further apart, they get closer together. So classically what happens is one of those things, but usually what will happen is you take someone who's used to having regular monthly periods, the interval may stretch out a little bit, so you go from 28 to 30 days to 35 or 40 days. You just skip months altogether, and then you come in and you're thinking, I might ask someone, when was your last menstrual period? It was in July or something like that. And then you eventually get to the point where your last period was more than a month ago, or more than a year ago, and then there you go. That's menopause. Vasomotor symptoms are those kind of classic hot flashes, night sweats. That's what a vasomotor symptom is. So thank you. I'm sorry about that. And those are the changes that people will complain. So usually it's hot flashes, night sweats, and changes in your menstrual period. Those are the most classic things that people will describe. Okay, so again, this is where we're going to spend most of our time, treatment. And so treatment, you look at a couple of different things. Expectant management is basically doing nothing. I tell you that it's okay, that it's a normal process, and that you don't necessarily need to be treated. We'll just watch it. If it gets worse, we'll treat it. Or if you have, these are some just little things that tips and tricks you can try. That would be expectant management. Hormone replacement therapy, and again, we'll go into that in depth, and then we'll talk about treatment options that are non-hormonal. And so those are basically the choices that we all have. So hormone replacement therapy. So again, and we'll talk specifically about what they are, but these are the benefits of hormone replacement therapy. You basically alleviate the symptoms, okay? So your whole idea is that you're making estrogen, so you're not having the symptoms. You stop making it, and so you just basically give the hormones back synthetically. So that is that. But some of the other thing, in addition to alleviation of the hot flashes, you have it's bone protective, so estrogen is good at preventing that, osteoporosis. Generally, people feel better, urinary incontinence improvement, and again, that's controversial, and we'll talk about that. If you have atrophic vaginitis, then you improve that, and so intercourse is less uncomfortable. Memory, that's debatable, but we'll talk about that. So these are some of the general benefits, and most importantly, it's just kind of a quality of life issue, and we like to all have a good quality of life. And if you treat it almost always helps the symptoms, and so that's where the benefit comes in. So, but there are some people who cannot do hormone replacement therapy, and these are some of them: pregnancy, breast cancer, estrogen-sensitive tumor, and that is usually either breast cancer or uterine cancer. More times than not, if you have uterine cancer, you're treated with removal of the uterus, and then that maybe opens up the door for that. But that's considered an estrogen-sensitive tumor. If you have vaginal bleeding and you don't really know what it's coming from or why that's the case, then you wouldn't want to be on hormone replacement therapy for that until that's squared away. Severe liver disease, because the liver is how you metabolize hormones, and so if you have bad liver function, then again you might have trouble breaking down the hormones, and so you might want to not do that if you have active liver disease. Use things like hepatitis or cirrhosis or something along those lines. If you have a history of a blood clot either in your leg or your lung, then you should not take hormone replacement therapy, and that may be you were in a car accident when you were 14, you had a blood clot. I mean, that basically just nullifies you right there. So those are all reasons to not take these. And then coronary heart disease, and again, we'll spend some time on that as well. How is hormone replacement therapy given? History of venous thromboembolism, that's the blood clot in the legs or the lungs. There's pulmonary embolism, that's called PE, and then there's DVT, deep vein thrombosis, that's usually a blood clot in the legs. So any one of those things can lead to this. So estrogen. Estrogen is the hormone that basically does the job of alleviating the symptoms, okay? And that is the gold standard for the relief of menopausal symptoms. And it's given in a lot of different ways. You can get a pill, you can get an injection, you can get a patch, you can get gels. There's a ring that you can insert in your vagina. There's a transdermal spray. So there's a lot of different ways that you can get estrogen. And then the progesterone is added to the regimen, not really to help the symptoms. It's not really given for that. But women who take estrogen, let me say, okay, so if you have a uterus, if you have not had a hysterectomy, then you need to be on both of these hormones, okay? If you have had a hysterectomy, you don't have your uterus anymore, then you typically will only take estrogen. And the reason that you take the progesterone is, again, to protect the uterus from overgrowth or endometrial hyperplasia. So, and it only takes about 6 months of taking estrogen alone without progesterone and having a uterus to increase your risk of endometrial hyperplasia. And the problem with endometrial hyperplasia, that's basically, again, a condition where you stimulate the lining of the uterus and it increases your risk of ovarian cancer. So if you have your uterus and you only take estrogen and are not taking progesterone, then you increase your risk of endometrial cancer by tenfold, so 10 times the risk. So it would be 1 in 1,000 if you did not take progesterone, or if you did take progesterone, it goes down to 1 in 100 if you are. So if you're taking hormones, you still have a uterus and you do not take progesterone, then talk to me. We need to talk about that. So that's an important deal. Okay. So the biggest study on hormone replacement therapy is called the Women's Health Initiative. It was published in 2002, and it basically changed everything. There's a show on VH1, Inside the Music. Has anybody ever watched Inside the Music? So usually a rock band everything's going great. They're winning Grammys and making a lot of money. Well, then the music always stops. And so the music will always stop. They'll have a commercial, and then they'll come back and they'll talk about the band's drug addiction or some kind of horrible thing happens to the band. In hormone replacement therapy, this is when the music stops. So when this study came out, it basically turned everything related to hormone replacement and menopause on its ear. And it was a collection of studies that was published in 2002. They had over 27,000 women in this study. So it was a big study. The average age, though, 63.3. Women under 50 were not involved in the study. Okay, so they basically, if you were less than 50, you couldn't get in it. And the average duration of follow-up was around 5 years. The study was said to have healthy patients, but they were a little bit overweight. Your body mass index is a calculation based on your height and your weight. And everybody has a number for what their body mass index is. If your number is 20 to 25, that's considered normal. If you're 25 to 30, that's overweight, and then greater than 30 is considered obese. And so, although they said all these women were healthy, they tended to be a little bit overweight, which we talked about obesity having some contribution to menopause. And then 50% of them or more either were current or former smokers, which everybody knows that's probably not the greatest thing in the world for your health. And then people who had really significant vasomotor symptoms, again, really significant hot flashes and night sweats, they were out of the study. So you took these groups of women and you divided them into 3 groups. You had one group over here that was the placebo arm, and that means they got nothing. So they took a pill, but it was just a sugar pill or didn't have anything in it. They were still taking things, but they didn't know if they were getting hormones or not. You had another group of women that took both estrogen and progesterone, and so these would have been the women who had a uterus. And then you had the other group that was just estrogen alone, okay? And those are women who had had a hysterectomy and were just taking estrogen. So the CEE is conjugated equine estrogen. That just means the type of estrogen they were receiving. And then the MPA is medroxyprogesterone acetate. So that just means they were taking estrogen and progesterone. The estrogen alone, they just took estrogen, okay? There was a pill, and still is, called Primpro. I don't know if y'all have ever heard of Primpro. This right here, that's Primpro, okay? And this is just Premarin, okay? So if you were going to go by a trade name or if you had ever heard of that, that's what it meant. So what they were looking for in the study, they weren't trying to figure out, is estrogen beneficial for hot flashes? We knew that. That was before the study, that was well established. After the study, that's still well established. What they were looking at to see if women who had heart disease, if taking estrogen and progesterone would benefit them. So that's what they were looking at. And they considered to be a bad result breast cancer. So one of the things that they specifically set out to determine is taking hormones, does it worsen or exacerbate breast cancer? So these are the kind of the nutshell findings of the Women's Health Initiative. Increased risk of, or taking hormones increase your rate of breast cancer, increased your rate of coronary heart disease, increased your rate of stroke and blood clots. It was beneficial or helpful for osteoporosis, and it caused also a reduction in colon cancer. Okay, so the breast cancer increase, again, we'll go through. Let's kind of look at these one at a time. So, not looking at the placebo group, we're looking at the combination group. These are women who took estrogen and progesterone. So these are the kind of the bottom line numbers. Hormones were bad. Hormones were bad for heart disease, breast cancer, and strokes and pulmonary embolism, blood clots in your lungs. And this is what they were: 30% increased risk if you had, or it made heart disease 30% more likely to happen. Breast cancer, 25% more likely to happen. And stroke and pulmonary embolism, 40% more likely to happen. But these are some better numbers to think about. So coronary heart disease. So heart, this is when we talk about, the red dress initiative to raise awareness for heart disease. And this, just to mention this, heart disease, the number one concern, the number one health concern for women in the menopausal age range. Okay, so it's a big deal. But 39 women out of 10,000 had heart disease taking hormones. 33% or 33 women out of 10,000 had heart disease if they didn't. So an additional 6 women out of 10,000, that was what, so when you say the risk is increased, that's what the number means. 39 out of 10,000 versus 33 out of 10,000. So when you hear that, you think, well, that's not really that bad. Statistically, it makes a difference, but in the, when you think practically, there's a 6 chance, or there's, out of 10,000 chances, there's 6 that I might have this. Does that make sense? That's how I kind of think of the numbers there. Breast cancer, a slightly increased risk, and I'm not disputing those numbers. I'm just telling you kind of what they mean. The stroke and blood clot, 34 women out of 10,000 if you take hormones, 16 women out of 10,000 if you don't take hormones will have the complications. So again, you're looking at maybe 18 out of 10,000. That's what the numbers mean. Bone fracture was helpful in the same thing there. 43 women out of 10,000 will have osteoporotic fractures. 72 women out of 10,000. So those are just what the numbers mean. So I don't want you to think like, oh my God, if I take hormone replacement therapy, I'm definitely going to have breast cancer. That's not what the numbers mean, and they didn't say that. Okay, so just the estrogen group, the women who were not taking progesterone, only estrogen, this is what the end result for them ended up being. They had an increased risk of stroke, and they had a decrease in their risk of osteoporotic fractures. So both groups, osteoporosis was benefited by hormones. Both groups, stroke risk was higher. Okay? And these are what the numbers mean there. So heart disease, a little bit increased when you take estrogen. Stroke, a little bit increased. Breast cancer, maybe some benefit. It's questionable. It just depends on how you slice the numbers. And then I put this up here. When we do, to determine if a study is good or not, or if it's helpful or not, you want to know if it's statistically significant. So anytime I say that it's statistically significant, that holds weight. Anytime I say it's not statistically significant, you can kind of take that with a grain of salt. That's kind of what that means. Okay, the key, though, and this is what I think is probably more important than anything else, because women were really scared after this study came out, and a lot of women still are, about the findings of the Women's Health Initiative. Mortality was not affected by taking hormone. Mortality means death. So in other words, if you take hormone replacement, you are no more likely to die than if you don't take hormone replacement therapy. So again, I don't want you to feel like you're taking hormones and you are a walking time bomb waiting for something horrible to happen to you. You may have some complications, but statistically, it does not cause an increase in your risk of dying, which is important, right? So at the end of the day, these are the things that these are the conclusions that we can draw. So your regimen should be individualized. So you may use something different than you may use, and you may use something different. So everybody can do something a little bit different. You can't make a blanket recommendation that all women should be on this dose of estrogen and this dose of progesterone. You just can't do that. So you individualize the regimens based on a woman's symptoms. You take the lowest effective dose for the shortest amount of time possible to remedy or to get relief of the symptoms. All right? And so you don't use it for prevention of heart disease. You don't use it to prevent Alzheimer's. And really, although I have it up here, it's not the first-line agent to use just to prevent osteoporosis. You use it to treat symptoms of hot flashes, night sweats, vaginal dryness. But you don't use it to prevent strokes or heart disease. Okay, now these are a bunch of things, and I won't go through every one of those things, but you have them. So we can make some conclusions. Is taking hormones beneficial or harmful for these things? And the important thing is they may have a little bit of a change for some of these things, and you can kind of read these and draw your own conclusions. Some of these, ovarian cancer, for example, there's a slight increase in ovarian cancer if you take both estrogen and progesterone, and that usually means if you take it for more than 10 years. Well, most women probably don't do that, so that's something worth considering. Dementia, cognitive function and dementia, that's one of those things that it just kind of depends on how you look at it. There's no improvement in dementia with hormone replacement. So if you are taking it specifically to make sure that you don't have Alzheimer's, bad reason to take it. Okay? It may increase your risk of developing dementia, although it usually is if you take it later. So a lot of times these studies will look at older postmenopausal women and younger postmenopausal women. And that means younger postmenopausal women 50 to 59, older postmenopausal women 60 or older. Okay, so that's what some of those studies will mean. The bottom line on dementia, it's probably helpful early, it probably is harmful late. But all of these things, again, they don't necessarily mean that you should or you shouldn't take it based on these things. Lung cancer, I put a bunch of abbreviations here. Women on combination ERT or HRT, that is hormone replacement therapy. The NS means non-small cell lung cancer. That's just a specific type of lung cancer. Okay, so not all lung cancers, just that specific type, had shorter survival. Kidney stones, no different. Quality of life is probably better for women who take hormones. Mortality, and again, we talked a little bit about that. But there are some studies that suggest that hormone replacement therapy decreases mortality in younger women, but not in older women. They had one study that put together a bunch of other studies, and it said that mortality is 27, in other words, risk of dying is 27% lower in women who take hormones versus women who don't take hormones. So, again, something that's out there. Okay, so I said that we would talk about incontinence, and I'll just address that one. Oral, so pill, hormone replacement therapy tends to cause worsening incontinence. If you take transdermal or a patch for hormone replacement therapy, that tends to not cause the same degree of incontinence. So it's a little bit iffy. Again, some patients who have pain with urination, recurrent urinary tract infections, that's actually better with hormones. Incontinence can be a little bit worse. But again, these kind of the things that I called nuggets, they're basically, I wouldn't look at this and say, well, it makes my skin prettier and my wrinkles less, so I'm going to take it for that reason. If you want to pile all these things and come up with your, okay, these are things that I think are important, and then you want to make your plus-minus list, then that's an okay thing to do. But I wouldn't say, well, it's going to make my incontinence worse, so I'm just not going to take it. I don't think the numbers would suggest that that's the best idea. Asthma, lupus is what systemic lupus erythematosus is. Raynaud's phenomenon is you get in cold weather and you get numbness in your fingers and toes. That's not a real common thing, but that's what Raynaud's phenomenon is. Uterine leiomyomas is fibroids. It might make your fibroids grow a little bit, but usually patients don't have any more symptoms after menopause related to that. Epilepsy, it's not, so if you have epilepsy, you can still take hormones. You just got to be very cautious and conscientious about what your doses are and make sure that the doctors who write your epileptic medicines know about it. So that's important. Migraine headaches, a little bit there. Okay, so that's the ins and outs, and I'll be happy to talk about specific questions because you may have more questions about that. But just in the interest of time, we'll move on. Bioidentical hormones. So what are bioidentical hormones? These are considered natural hormone therapy. They're usually they're individualized by pharmacists. So typically what happens is you go in, you give a saliva test, and they come up with a hormone regimen with one or some of these hormones right here based on what your saliva testing comes out to be. Estrogen is broken down into 3 different types, and then you have progesterone, they might have testosterone, and DHEA is just a derivative or another type of testosterone. So if you've ever done this, you'll go give your sample, they'll come up with a recommendation, and then they'll make up a method or a group of hormones just for you. Okay, the problem with these, they're not regulated by the Food and Drug Administration. That's what the FDA is. There's a lot of variation between one batch and the next batch. And although it's thought to be safer because it's more natural, there's really no evidence that the side effect profile is better. There's no evidence that they're more efficacious or effective. There's no evidence that it's any safer than taking pharmaceutical hormones. And then expert groups, meaning like the National Endocrine Society, the American College of Obstetricians and Gynecologists, don't necessarily recommend taking these for a lot of these other reasons because it's just not really policed as well. Okay? That being said, some women like it, and if you're happy, I'm happy. I don't think that they're necessarily harmful. And so, if you want to go that route, then by all means, I think that that's a reasonable thing to do as long as you kind of know these are the ins and outs. There are 2 places locally that do this. Boudreaux's New Drug Company will do this. They're on Sallier, close to St. Pat's. And then JJ's Prescription Specialties is on Nelson Road, close to, in the same shopping center as Que Pasa.
What have your patients had to say in regards to bioidentical?
I've had mixed results in my patients. Some patients will go and they really like it. Again, they feel better about it. They think that they're making good decisions. And then some patients will go and it just doesn't make a big difference. They might be a little more expensive than some of the other regimens. I'm not real sure about that. But again, I mean, if you have disposable income and it works and you can do it, then by all means. Again, my goal is to make you happy. And so if that makes you happy without harming you in any way, then that's something that I'll encourage that. Okay, non-hormonal treatment. So this is basically everything else that is not either estrogen or progesterone. Okay? So just simple lifestyle modifications, things that you can do, and a lot of these will just make sense. Okay? Dress in layers, lower the temperature in your house. Most of you would already just think to do that. Weight loss helps. Aerobic exercise helps. If you drink alcohol or eat spicy foods, that might make things a little bit worse. Okay, selective serotonin reuptake inhibitors is a medicine. These are classically antidepressant medications. And this group of medicines and gabapentin, which is another medicine we'll talk about, probably the best non-hormonal treatments that are out there. Okay, they're effective in reducing the hot flashes. They've had a lot of different studies that have looked at this, and they've been, for the most part, very helpful and have demonstrated that they're effective. And then for patients who can't take hormones, this is usually a good first place to start. Okay. These are some examples. Paroxetine is Paxil. When you compare taking Paxil to taking paroxetine or Paxil, when you compare taking Paxil to taking placebo, which is nothing, Paxil tends to improve your result by 41%. Now understand, you've all heard of the placebo effect maybe, and that's I give you a medicine that is nothing other than a sugar pill. Usually 33% of the time you're going to say, I feel a lot better. You're taking nothing, but you're taking something that makes you may not know the difference, and so people tend to feel a little bit better. So when you hear the term placebo effect, just taking something, even if it's a vitamin that you don't know any different, you feel a little bit better. So they're comparing those two things, taking this medicine versus taking a sugar pill. 41% better. And then Effexor is one of the other common medicines that we use in women, and that tends to help as well, 31% or 33%. Celexa, Lexapro, Pristiq, they all have some numbers, but they're not quite as good. Zoloft, Prozac, there's also some studies that have looked at those. But these Paxil and Effexor tend to be the most effective too. And then there's another medicine called gabapentin, also called Neurontin. It is not FDA approved for treatment of hot flashes. It's mainly used for seizure disorders, for post-herpetic, meaning after a herpes outbreak you have nerve pain. It's used for that, and then neuropathic pain. You have shooting pains in your legs. Some of those patients are on Neurontin or gabapentin for that particular indication. But it is effective in reducing hot flashes. It's often taken at night, so you can take a dose of 300 to 600 milligrams at night, and it tends to help nighttime hot flashes do a little bit better. Okay? So that's that. There's another group of medicine, the progestins, and we kind of talked a little bit about this when we talked about progesterone. These are not really studied as much, but I think that there's a suggestion that they work a little bit better than some of the other medicines. So I think over time you're going to see more information or data on these things. And usually you have to take a little higher dose than some of the other reasons that you might have to take progestin medicines. And some of the examples, there's a medicine right here called Megace. There's a medicine called Depo-Provera, which is most often, you think of this most frequently as a birth control medicine, a shot that you get every 3 months. And then this is a pill medicine called Agestin or Norethindrone that you can use as well. The biggest problem with that, it makes you eat a little bit more. Actually, Megace is a medicine that you use, for example, ovarian cancer patients who are not able to eat very much. They a lot of times will take Megace to stimulate their appetite. So weight gain is one of the things that you have to watch out for. And of course, nobody likes to gain weight. And that might be one of the things that preclude these medicines across, for a lot of different people. Okay, Clonidine is usually thought of as a blood pressure medicine. So it's either a patch or a pill that you take to lower your blood pressure. And it has some side effects that people don't like. That's probably one of the main reasons that it's not used across the board, but it does work. It does help with hot flashes. Okay, so then beyond here, we get out of the pharmaceutical world and into what's called complementary and alternative medicine. So these are holistic things, herbal things. This is the group of medicines that we're talking about here. The big picture issue is that all of these medicines, and this is like ginseng, ginkgo biloba, some of the vitamins, and we'll talk specifically about these. But these are things that are they're not regulated by the Food and Drug Administration again. So when I was in, I think, medical school, they had more people in the Food and Drug Administration that were testing the validity of medicines for dogs than they were looking at these types of medications. So that's changing because this is becoming big business, and the Food and Drug Administration is looking harder at these types of medicines. But still, the safety and the what you see is not always what you get. So that's one of the problems with these medications. But that being said, the majority of women will use this for symptoms. And so, again, like I said, if it makes you happy, then it makes me happy. But these are the things about it. Phytoestrogens. So this is soy. Okay, so soy products, all right? They are non-steroidal compounds usually found naturally in plants. They're generally not thought to be any more effective than taking a sugar pill. And a lot of studies will bear that out. Some studies, again, I got something in the mail yesterday from some soy group that said, that their study shows that it's better. Again, you can find studies to prove everything, and there may be some women that have benefit from that. So, for what that's worth, they have basically pro-estrogen properties and anti-estrogen properties. There's another medicine called tamoxifen, which is used for patients who have breast cancer. These two medicines don't go together, and so there's a thought that this may stimulate breast cancer growth, and so if you have breast cancer, it's an absolute no-no to not take these. These are the types of isoflavones, some of the things that you've heard about. I mean, if it was chickpeas, and if you like hummus, I love hummus. I could probably eat enough hummus to make my hot flashes go away. The other one that's that you hear a lot about is red clover extract or red clover. Again, no more effective than taking placebo pills. Black cohosh is another one that's probably most widely used among this group of medicines. Again, questionable about whether or not it worsens breast cancer, and it's no more safe than a placebo, or no more effective than placebo. Evening primrose oil, it's used widely to treat hot flashes, but really no more effective than placebo. Acupuncture, it's been studied and looked at, but the results have not been that promising. I'll explain this one. No significant differences between comparing acupuncture to sham acupuncture. What sham acupuncture is basically fake acupuncture. Okay, so you do a real acupuncture versus kind of a fake acupuncture. I mean, you can't, you either know if you got needles or not. So that's what sham acupuncture is. People who do that, I mean, there's a little bit of a science to it, so they're not just jabbing you with needles. But if you did just jab somebody with needles, that would be called sham acupuncture. Okay, and honestly, I don't really know that much about it. If you've ever had acupuncture, you could probably teach me that it's a little more complicated, and this is what it means. But anyway, these are other things that people have looked at: ginseng, dong quai, wild yam, progesterone cream, reflexology, magnetic devices. Again, no more helpful than placebo. So, just to kind of wrap it up, what do all these things mean? If you just take away some of the important things, short-term estrogen therapy is effective treatment for hot flashes and night sweats. Short-term is defined as 2 to 3 years, not more than 5 years. Vaginal moisturizing agents, things like Replens, Lubrin, they're helpful. Lubricants with intercourse, something like Astroglide when you have intercourse, and low-dose vaginal estrogen can be used for urogenital atrophy. That's basically the thinning of the vaginal lining. That is probably helpful. Estrogen is not a good idea just for osteoporosis prevention. So if that's the only reason you're taking the estrogen is to prevent osteoporosis, probably not the best idea. You should maybe take a bisphosphonate medicine like Fosamax or something along those lines. Estrogen is not indicated for coronary heart disease. And when hormone replacement therapy is not an option, you either try gabapentin or one of those antidepressants like Effexor. And then for women who have breast cancer, you need to be very cautious about some of these soy products and black cohosh. These are some resources. If you look on the internet and you type in hormone replacement therapy, watch out, you're going to get all kinds of stuff. This is probably some of the best stuff that you can get your hands on. This Up to Date is a really awesome site. It is broken up into clinicians who pay for a subscription get access to one group of information, and it's usually very wordy. This is not something that most people who are not physicians would want to read about. Then there's 2 different groups of patients. It'll have basics and then beyond the basics, but these are good resources for patients. And most of that stuff is free. So if you go to Up to Date and you type in hormone replacement therapy or basically anything. I mean, any medical issue, and you go to look for patient information, then you can get access to that without paying a bunch of money. The NAMS, or the North American Menopause Society, is very patient friendly, and so they have great information for this. Okay.